We have actually a lot of data with Nivolumab. So there are two oral abstracts, which I think will be the focus. So one of them is a combination of chemotherapy with Nivolumab. So last year I presented at ASH as well as EHA earlier this year the data of hypomethylating agent with Nivolumab, which is actually looking quite good. We now have about 70 patients in the salvage elderly AML group where we're seeing response rates about 35%. And more interestingly, especially in the early salvage 1 to elderly relapsed AML, we're seeing median survival above 10 months. And at 2 years, we're seeing 35 to 40% alive. So this is not something we have historically seen in elderly salvage. In fact, this is what we see in the frontline elderly where you have median survival of 7 to 10 months. So this is a very encouraging signal with a good number of patients. Based on that, we've moved it to the frontline where we're doing AZA with Nivolumab frontline, and I have a poster on that tomorrow. And in the first 16 patients we're treating, we have an overall response rate of about 65%. So it seems that in the frontline, this combination is doing as good as any other combination. Now we have to wait for the durability as well as survival. We do see the immune toxicities, like I discussed. We've gotten better in our group in managing them because now we've treated more than 200 patients with different Nivolumab or pembrolizumab or durvalumab combinations, and with that, we're seeing very less severe toxicity. So as soon as we see any evidence of pneumonitis, nephritis, we treat it. The other oral here will be presented by my colleague, Dr. Avandi, who's doing a little bit different approach where he's doing chemotherapy, Idarubicin cytarabine, which is standard backbone for AML induction in younger patients this time with Nivolumab. And he's going to update our phase 1/2 study on that. Basically, this was a study to show, was it safe to give an immune therapy with induction? And the answer is yes, it seems to be quite safe. The incidence of immune-mediated toxicities is somewhere in the range of 10 to 15% when you take all of them together. But again, none of them led to serious ICU or fatal events or patients coming off study. So these are manageable. The response rate was about 75% CR/CRI, which is similar to what you would get with Idarubicin cytarabine. But really, the goal of this study was to see, can you add a immune-activating agent that increases T-cell surveillance, improving your duration of response. And we are seeing now a signal that there is a trend for improvement in CR duration with IA Nivolumab compared to our historical group of IA patients, which is about 130 patients. We have a nice historical clinical trial IA group. So we need to give more time, probably another 1 or 2 years, to let this mature. But this could be showing what we are looking for, where there is an improvement in the CR duration. And the third, which is another oral abstract that one of my fellows, Dr. Williams, will give, is looking at AML in general to see what is the T-cell population in AML and what checkpoints they express. And what we do see is that the T cells are actually quite well preserved in AML, even in relapsed AML, but in the early relapse. Once you get beyond second, third relapse, you start losing T cells. These people have had lots of high-dose chemotherapy, and those are probably not the patients to go for immune therapy. So you want to bring these immune agents early on. The other thing we notice is not only are there preserved T cells, there's actually an increased Treg population as well as increased CD8 population, which basically shows that the T cells are responding towards antigens in the bone marrow. So there is a active immune infiltrate going into the AML bone marrow. And we also see that at least 2 major checkpoints, PD-1 and OX40, are significantly increased in the AML bone marrow on the CD8s as well as CD4s and Tregs, which is something that people have not really seen before. So it's quite interesting that AML is behaving like an inflamed tumor where you do have T-cell infiltration, both CD8 and Treg. They have activated phenotype, they express HLA-DR, CD69, and on top of that, they have particular checkpoints. We looked at about 8 to 10 different checkpoints, but the ones that stood out was PD-1 was high in AML as compared to healthy donor, and then OX40 was high. So based on this, there's now in our group an effort to build newer checkpoint combinations. We've already done PD-1, but we're also looking at CTLA-4 ipilimumab as well as OX40 because these may actually be as important or more important based on our preclinical data in AML. So a lot happening in that space as well, yeah.